So today we are going to be talking first about, we're going to have our guest Edwin Lindo, and I'll introduce him when he hops on, but we'll be talking about critical race theory in medicine, and then followed by talking with Paula Houston will be talking with us about her work with the Office of Healthcare Equity, and specifically this equity tool and equity framework that's been developed and they've been using to look at policies, new policies, QI interventions at Harborview to ensure that that there are equitable policies being put in place. And then after that, we actually have a little bit of time to break into small groups and talk about the morning, and then also go through our wonderful Harborview QI chief, Fisher, has some cases, some QI cases that have equity issues, and we will have the opportunity to think through those together and use the equity tool to think about how possible proposals may or may not be equitable, and how what we can do to help make sure that we are developing policy proposals and taking care of our patients in an equitable way. Let's see. Yinka or Anna, anything else that you want to add?
No, I think that was a beautiful overview. I think I'm really excited, especially for when we break into the small groups with this with the QI cases. And we'll remind you once we're in those small groups as well. But just to reiterate how this is, they're real cases. Reading the cases might bring up a complex amount of emotions for folks. And so holding space for that, and also recognizing that we're this work that we're trying to do is messy and complicated. And so just being really open to and vulnerable as we kind of discuss what we think would be ways to continue to help make our program and the way we care for patients more equitable. So going into this day sort of with that framework that we're all learners here, and doing really hard work. And so also holding space for that too.
Great, thank you for that, Ayinka. So I think our first speaker is not quite here yet, but so I think we can just maybe relax for a minute or two. And I'm not sure if there's a good way to let everybody know when we're ready to get started. So maybe just relax, enjoy your morning cup of tea or coffee or breakfast or whatever, and we'll get started in a few minutes here.
I can hear you. Can you hear me?
We can hear you
Okay.
and see you. Thank you for
Perfect.
being here.
No, absolutely. Let me set this up.
Yeah, I can do just a brief introduction while you get settled, Dr. Lindo, if that's all right. Can you hear me okay?
Yeah. Okay, I think I can hear you now.
Okay.
Yep.
All right. Well, yeah, it's our honor to have us with you here today. Thank you so much for being here. So just a brief introduction for the rest of the group. So Edwin Lindo is Assistant Dean for Medicine and an assistant professor in the Department of Family Medicine. He's a critical race theory scholar, an educator, community organizer, and teaches, presents, and writes on issues of race and racism in medicine and in society. He's also co-founder of an awesome library, Estelida's Library, which is a justice-focused community bookstore and library in Seattle. I'll turn it over without further ado to you, Edwin.
Awesome. Thank you so much. It has been a wild morning and past few days, as I'm sure it is for a lot of folks. So let's hold some space if we can. I know I'm late, but it's been heavy. It's been heavy for a lot of folks, for the work that you all do, for you to have to carry a lot of the trauma and suffering that the patients come and see you with, and that's real. And I think we need to take time sometimes to just feel it, to share it, to hold it, and also realize that it's very difficult to say, well, I'm just going to walk away from it. And I think building that community, building a collective of folks that can hold each other up. And I know residency is incredibly difficult. The demands, the time, the expectations, without a doubt. You may know, but Dr. Williams is my partner, and just having her seeing her go through residency was tiring for me, and I didn't even do it. And so I can't imagine this process. But I also know that what you all are doing is a means to get to a place where, particularly for the melanated folks on this call, that you are setting an example. You are the inspiration. You are the hope for many communities that never had seen a doctor that looked like them before. I say that because Dr. Williams, amazing Black woman from deep East Oakland, has patients that write her handwritten notes that say, "You are the first Black doctor I've ever seen in my life." Right? That's a lot. That's a real thing, and it's unfortunate that that still happens in 2021, but it's the reality that we sit in. And for other folks, it's also taking on the responsibility of ensuring that we are taking care of people who don't look like us. That it takes some learning, it takes empathy, it takes practice, it takes some internal investigation and interrogation of not just biases. Biases is the nice word that we use to not call the thing what it is sometimes. It's a conditioning that we've been brought up in this country. And we've seen it clearly. January 6th was very clear. January 6th told us, let's not forget what this country was built on. Confederate flags running through the federal Capitol was not an accident. Many people were astonished and surprised and terrified. And they said, well, Edwin, what do you think about it? And my response is, the only surprise that I have is that it didn't happen sooner. Because this is what our country was built on. And we can have a debate all day long of, well, Edwin, how dare you? You're so nihilist. I can't believe that you would say something about this country. I have many people who say that I'm anti-American, which is fascinating to me because, like James Baldwin said, I love this place so much that I reserve the right to critique it. But systems don't like to be critiqued. But that critique takes grace, it takes relationship, it takes community. And I do it through a lens of critical race theory. I don't want this to be an incredibly didactic presentation. I want it to be a place where you all can ask questions, because what I've learned through my time here is that we have questions that we sit with, unsure how to ask them, even more unsure what the answer is. But I think in this collective group, we can start exploring how we have a better analysis of the world that we live in and the system that we operate in, the patients that we take care of. And so I'll quickly, but to leave room for discussions, and I know there's a breakout group after, to share what critical race theory is. These are super simple slides and concepts. I am not an artiste, and so there's no color. It is just getting to the heart of it. For those that don't know, critical race theory is an academic activist framework, theoretical framework that gives us language and a lens to interrogate the conditions we live in. It is not to provide us the answers, but it's to help us to ask the right questions so that we can get closer to the answer. And those are a very necessary distinction. I think, unfortunately, a lot of academia, including medicine, sits in the tower of, well, I'm going to provide the answer. And as you all know, there is a lot of situations where a patient presents to you and you're like, I don't know what the answer is. I need to get a second opinion. I need to speak to my chief. I need to speak to my attending. It's a collective process of understanding what the conditions are. I'm giving this example because the truth is you all practice this already, right? You do a differential diagnosis. You're saying, let me look at what the facts are. Let me know my understanding of physiology, biology, and pathology. And how do I explain what is presenting in front of me today? That's what critical race theory does. Unfortunately, most times people get upset with it because we're more realist. I'm just saying, look, I don't have to live in this fabricated world that suggests that there's no racism, that suggests that everyone's free, that suggests that everyone is equal and just. I'm okay knowing that I live in an unjust world. It's not okay that it is unjust, but there's no reason to lie about it. There's no reason to try to blind myself to it, because when that happens, we're living a lie. We are living under a veil that makes us feel comfortable enough to maneuver through the world when millions of other people don't have the veil, and the veil is not helpful for them. And so critical race theory kind of rips it open and says, let's just call it what it is. We live in a perpetual state of systemic institutional racism that is clouded with hegemony, patriarchy, cissexism, sexism, and many other isms that exist in our society. But we, if we're clear, started from a place of racial capitalism, exploitative racial capitalism in this country. And you say, well, how so, Edwin? What does that even mean? It means that chattel slavery was the economic foundation for this country. That being true, everything else wouldn't have existed economically, politically, were it not for the taking of indigenous land and the slavery of Black folks. The banks, the schools, the endowments for Harvard, they all came from the same place. And some people say, well, what's the point of sitting in the past, Edwin? Why does it matter? Let's move forward. Think about the future. Let's be happy. Let's be joyful. And I'm like, yeah, I would love to get there with you. And we can't get there unless we know where we came from. So critical race theory says, look, we're not here to sit in this magical world that's made up. Let's be real about it and let's call it what it is. And most folks don't like it because, unlike the traditional civil rights movement, which was necessary and beautiful, also embrace incrementalism and progressivism. Critical race theory questions the very foundation of the liberal order. And you say, well, I thought I was liberal. I thought voting for a current person in office was liberal. Liberal is not a critical analysis. Liberal is just a political position on a spectrum. Critical race theory doesn't sit on the red or blue spectrum. It sits outside of it that says we're here just to ask the right questions. I'm both critical of the previous administration as I was the administration before him, which was President Obama. Because if we believe that an identity alone is going to be the magic bullet, we again have tricked ourselves. And so instead of saying, for example, that Brown v. Board of Education, who remembers Brown or not? Let me rephrase it. There may be people here that were alive during that time. I don't know everyone on this call, but who is aware of Brown v. Board of Education? Can someone unmute and tell us what that case was about? You're like, Edwin, I did not sign up to go to law school. I am a resident. There's not going to be a wrong answer. We're going to piecemeal the answer together.
Wasn't it about school segregation?
It was about school segregation. That's right. Do you have an idea of what era it was or what time span?
50s.
Yep. So
Yeah.
50s and 60s. Yep. So it spanned. There were a number of cases. There's actually 2 Brown v. boards, but yeah, late 50s. When you say was talking about segregation, was it segregation of people with blue eyes and brown eyes? Like who are we talking about?
Segregation of Black students between different school districts.
Segregation of let's be a little more clear. So Black students were segregated amongst themselves.
I think what Hasib is trying to say is it was segregation between Black students and white students, with the argument being that they were receiving a separate but equal education. And so that was sort of the...
We weren't at separate but equal quite yet. We're close. They were suggesting that in the legal arguments, but that wasn't law yet. But yes, that's good. Do we know where this ended up? What did Brown v. Board decide? What was the final decision?
It forced a political decision to push for school integration.
For school integration. Good. Do we know what was, and thank you for using the word force political. That's good. That's accurate. What was the result of that? What students were integrated into what schools?
Black students were brought into white schools in demonstrations of integration.
Mm-hmm. Why wasn't it the other way around?
Because white schools were deemed to be better quality.
Mm-hmm. And so the assumption was, if we put Black students in white schools, they were presumably get a better education?
Yes, and white students and white families wouldn't be eager to send white students to Black schools.
I think that's what we can look at now. That wasn't the argument at the time. I think it was on the premise of, well, clearly white schools are better and they'll better educate. Now, how do we fund our schools in this country, our public schools?
Usually like property taxes.
Right.
Places.
And what is it based on? Which schools receive more money? Knowing that property tax determines where the source comes from, and how do they allocate those funds? Based on what? I'll help us out here. That was slightly tricky, but it's based on the number of butts that are sitting in a seat in a school. So the more students you have, the more funding you will receive. So now we start getting interestingly closer to the answer of why this type of segregation. Why didn't the white students come to the Black schools if they're saying integration was good? Well, the moment that forced integration occurred, white schools were now receiving exponentially more funding, significantly more funding. Now, another question is, what happened to all the Black teachers? Were they integrated into white schools? No, so that means there's a whole generation of Black teachers that lost their careers. Those schools disappeared. They had to become laborers, field hands. These were professionals with PhDs and master's degrees. Immediately, no job. And was there any evidence to suggest that integrating Black students into white schools would actually provide a better education? There wasn't. That was never presented in the court. Again, it was a presumption. I forgot who said it, but it was a presumption that that's what would occur. Now, interestingly, the question at hand in the legal case was not how do we bring better education to Black students? How do they receive a better education? The question wasn't even in after integration, you are forced to provide the same education. The question was simply, will we integrate schools? And they did that, but there was no obligation and or responsibility to actually provide the same education. Now come to 2021, we have here in Seattle, Garfield High School in the south end of Seattle, in the Central District. I see someone smiling. What do you know something? I feel like we know the same thing. I don't know your name. It says internal medicine residency, but I'm assuming that's not your name. Oh, you're on mute. You're on mute.
It's my alma mater. I graduated from Garfield.
Oh, you did? Then tell us what the students called Garfield, the ones that are on the second floor and the ones that are on the first floor.
There's a lot of names, but I mean, Garfield was very segregated, as you demonstrated by floor.
Yep. And I've heard some students call it the slave ship.
Yeah.
Where they know that the AB and advanced classes are on the second floor where the majority of students are white, like overwhelmingly, close to 95%. And the first floor is where the Black and Latino students are. Again, never said that you had to educate them at the same level or provide the same resources once they're integrated. They just had to be in the same building. I dragged us through this because critical race theory helps us critique. A liberal approach would say, this is great. It's unbelievable. We've integrated schools. We've reached the apex of post-racial ideology. We're just, we're fair. But without the deep critical critique, we just settle there and we say, yeah, we did our job. The critique from CRT will tell us, are we actually achieving the thing that we were meant to achieve or that we were trying to achieve? Because it doesn't feel that way. How do we know that? The data shows us that when integration occurred the way it did, you definitely had a gap in education. You had Black students that had fewer resources in the schools. They were getting the old books from the white school districts. Then you had white students that, and these were based on standardized tests, which inherently have biases. But when integration occurred, that disparity grew. And white students were getting better educated and Black students not. And this was in integration. Now, I get a lot of people say, well, Edwin, are you telling me that you believe we shouldn't have integrated? No, I'm saying if we're going to integrate, then we should have actually done it for the purposes of providing better education and more resources for our Black youth, for our Black teachers. Imagine, knowing how schools are funding, if we actually said white students need to come to the Black schools so that Black schools can get more money, so that Black teachers can get paid better, so that they have the newest books. But that wasn't going to happen because it was still seeped in deep racism. But as mentioned earlier, it was a political decision because they didn't want to have an uprising. So they quelled that at the moment with saying, well, we've integrated the schools. As you can tell, critical race theory, and you can ask these same questions for nearly everything you come across. What is the deep critical issue? I know what I've been told is just, but is that actually just? Who is it just for? Who is the most marginalized in this scenario? And are they receiving the benefit of this so-called liberal decision? More often than not, that's not the case. You look at broken windows laws in New York City, that was a liberal decision. Oh, we need to keep our community safe. What they were really saying is we need to get Black people and Latino people in jail because we don't feel comfortable with them being in our neighborhoods. Gentrification helped reinforce that, help expedite that process. We see that here in the South End. our friend here that went to Garfield, the area around Garfield does not look like it did 10 years ago. The prices have exponentially gone up nearly 110%. The Black families that live there can't afford to live there. If you owned your home, and you say, well, just own your home, work harder, own your home. Well, the way real estate tax work is that if someone builds a house or a townhome next to you that increases your property value, and you're on a fixed income and grandma can't get more money, she can't afford to pay her property taxes anymore. So she's either forced to sell at an unreasonably low rate, or she has to leave. It's not an accident, right? So are there any questions or thoughts so far? I don't even know what time it is. Feel free to shout them out. If this lets me change the slide. All right, so here are tenets of critical race theory. Tenets that I've used in just the discussion that we talked about without actually calling them out. The first is that race is a social construction, a social political construction. You may have heard that, it's famous. I think everyone on Twitter is like woke because they know that race is a social construct. Great, that's a great place for us to start. But most folks don't know what that means. What it means is race is a tool that was created starting in the mid 1700s. And I'm saying starting as it was published in medical journals and biomedical journals by white scientists and physicians that created this hierarchy and taxonomy based on race. And that taxonomy has been and continues to be used for the purposes of allocating resources and rights. And unfortunately, the same taxonomy exists. So that means Black people, Indigenous people, non-white men, land-owning folks tend to not receive the same benefits as them. You say, oh, great, Edwin. Now you're saying that I have privilege. Edwin, I don't have privilege. I grew up poor. Okay, let's talk about that. Growing up poor doesn't mean you face racism if you're a white person. It means that you have been the victim of a highly exploitative, racialized capital system. And yes, you have faced levels of oppression, and it's real. But when we start conflating class with race, then we're not talking about the same thing. Those are two different experiences that can be compounded. That's where the definition of intersectionality comes in. That you can have a poor Black person that has experienced what it means to have to go to the store, buying their food with food stamps, eating government cheese, living in public housing, and know that if they walk outside and the police on Rainier Avenue, which use it as their driveway, see them doing what they think is suspicious, they're going to get pulled over. That's the compounding of this effect of marginalization and oppression. The other key tenet of social construction, I call it a social political construction, and sorry I didn't add that here, is that it has been used as the tool of pathologizing race. That is, as you've learned in medical school, you probably hear it in your training, that there's slight differences in people of different races. I mean, you see it in the way they talk about hypertension and high blood pressure and sickle cell and smallpox. Oh yeah, Black people are at risk for high blood pressure. Sorry, they don't say at risk. They say race, particularly Black folks, are a risk factor for hypertension, high blood pressure, diabetes. What does risk factor mean? What is a risk factor?
Yeah, we describe it as being like more likely, but then the natural question there is like, why are they more likely to have hypertension?
Right. And in risk factor, is there a pathology? Is there there's something biological to it?
There's nothing biologic about that for Black people in hypertension.
Well, right. But I'm saying when we say risk factor, because I'm thinking of hypertension, right? You can exercise, you can eat better. Like those are things that change your biology. You can also change those behaviors or change what you eat, where you go, depending on the conditions you live in. But race is the only one that you can't change, yet it's a risk factor. And it's suggesting that being Black is part of the reason why you may have hypertension, high blood pressure. And you're saying the same thing. I was just fleshing it out. And so I always ask the question when I see it on the slides, how is race a risk factor? Oh, Edwin, it's a proxy for something else. Oh, okay, well, great. Let's just use the things that we're proxying for and not use race. Oh, it's complex, Edwin. There's just so many things. Oh, like racism. Yeah, let's put racism as the risk factor. Because if you're saying race is the risk factor, like mentioned, well, why is that? There is nothing about folks' melanin that increases the likelihood of diabetes biologically. There is a higher likelihood of diabetes if you live in a food desert or food mirage, or however we'd like to call it. If you live in an area where you have low economic prosperity or access, and so going to McDonald's, getting not the freshest food is more affordable. And so that's what we're going to do so that everyone in our family can be fed. I'm still trying to figure out how that connection to race exists. Again, biologically, it doesn't. And I have many people that push back. Well, Edwin, I know that there was an oncologist that said, Edwin, I've studied that Black men have higher rates of colorectal cancer because, and this is the correlation I found, because of lower rates of vitamin D. I'm like, oh, fascinating. So that means if we give Black men vitamin D, you will eradicate colorectal cancer. Well, no, it's so much more complex than, yeah, because it's not race. Because if it was that simple, if race was that constant, if race was a constant biological determinant, then we would solve these issues a long time ago. But it's not that. If it were that also, that means everyone of the same race would have the same outcomes. And they don't. If sickle cell trait was a Black disease, then that means all Black folks should have sickle cell trait, but they don't. Only some Black folks do, usually those who are along the malaria belt. Oh, West Africa, the people we stole, brought to this land in forced labor. That is why we have higher rates of sickle cell trait in this country. It's not because it's a Black disease, it's because we've concentrated those particular Black folks. But if we look along the malaria belt, you go to Southern India, Eastern Europe, they have high rates of sickle cell trait because it is an evolutionary response of our DNA to try to protect us from malaria. And so it's not the color of our skin. It's not, especially not the race. Why? Because my race changes depending on the nation state that I'm sitting in. How is that so? If I go to South Africa, I'm colored. That's my race. If I go to parts of South America, I'm Indio, I'm Latino, I'm Hispanic, I'm Mestizo. Just in 2 continents, I'm 5 different races. You add the EGFR, which I'm glad our school has really, we got around, we started the task force. I'm glad to have been part of it. Amazing students pushing as well. We got it changed. Let me tell you how it changed. We have our lab scientists who are so great. I say that because they walked in the room and they're like, look, we don't actually, we're not clear on this whole thing. So just walk us through this. I said, great, I just have one question. Do you think that race is a social political construct? Their response was, yes. Great. If that's true, why are we using it as a diagnostic tool to determine kidney function? It's a good question, Edwin. Let's go back and do some research. They did, and they said, yeah, we don't know why we do that. It's based on a study from the late 90s that suggested Black people have higher creatinine serum based on muscle mass, average muscle mass. They suggested Black people on average have greater muscle mass. They studied like 700 Black people. Not a very high number. And they used that average and have now placed it on every Black person across the globe. And the question even falls harder on its face when you say, well, what happens when Barack Obama walks into your office and you need to measure kidney function? Which equation do you use, or which number do you use? Do you use his white side? Do you use his black side? And the response I usually get is, well, Edwin, it's kind of an art, right? We kind of fill it out and we think about other things. I was like, oh, this is fascinating. Now we're using art in medicine. To me, if we're using art in what is supposed to be a scientific precise process, that process isn't effective. And we got there, and we removed it. We're about to publish a piece that shows us the data. Granted, it's data of arrears, that if you were to apply the equation with the MDRD race equation and the CKD epi without race, the table was the same. The distribution was the same. It was lower because we were artificially increasing the EGFR of Black patients. And what happens when you artificially increase a number? When it comes to EGFR, if someone comes with a high EGFR, what happens? Let's say it's 60, let's say, well, it's not 60 because we're not measuring there, but let's say it's 54. You're going to have to come up with a plan.
Then they get labeled as having a disease.
You're getting labeled as having a disease. What happens if you want to transplant? If you want to transplant, your EGFR has to be below a certain number. What we found is, on average, this artificial increase in the EGFR was between 10 to 20 points. That's a lot, just based on this made up phenotypical description called race. Now, I usually give a similar talk and everyone's like, well, Edwin, then yeah, I agree with you. Let's just get rid of race. We don't need it. It's unhelpful. I didn't say that. That's not what I said. Do not write that in your notes. What I'm saying is race is unuseful, has no use as a biological determinant to try to delineate difference of people. However, it is an incredibly useful tool in understanding social and political class, relationships, culture, how we engage with each other, solidarity. That's an incredibly important factor of the way we move through life. But I don't need someone to try to study how my kidney functions different than a Black person's kidney or a white person's kidney, because then we're suggesting that there's a Black kidney, and that there's a Latino kidney, and that there's a white kidney. And if that's true, then we are acting no different than in 1776, where they were what they called polygenicists, and believed that people of different races came from different biological origins. They did not come from the same species. That was believed for nearly a century, which is wild and sad. And many people say, oh, that's pseudoscience, Edwin. I don't like to use the term pseudoscience because pseudoscience suggests that it sits outside of science and that only good things happen within science and all the bad things are the pseudo of it. I'm saying, no, science can do some bad things. I'm not saying science itself inherently is bad, but the outputs are just as equal as the inputs. And if the inputs are harmful, so will the outputs. And so we have to sit with that. We have a ton of equations. How many of you have used the spirometer? Are you familiar with the issues of the spirometer? Lindsay, I see you nodding your head. What do you know about the spirometer?
I know that there's also there was also some of the interpretation of results was based on the idea or thought that Black people have different lung capacity than white people.
Yeah, and it still does. You just don't have to make the choice any longer. It's embedded into the code of the technology. So the machines that we have in the hospitals automatically determine, based on the input of the person's race or identity, it gives you the number. But this is true for the VBAC equation as well. Deciding whether someone should have a cesarean birth or a vaginal birth, part of that equation is this person Black or Latino? And if they're Black or Latino, you are more likely to have a cesarean birth. Why? there is no good answer for it, because I've asked it and I've tried to find the answer. It isn't there, but it's because we do this poor. Race is a terrible confounder. So we do this confounding that, oh, we see these outcomes. The variable we're looking at that's so easy to identify is race. So therefore, there's more complications with Latino and Black folks. Oh, we're going to include that in the equation. No one asked the question, does that make sense? Is there a biological connection to that? Is there a genetic one? No, we usually, unfortunately, sit on the laziest pedestal, which is, oh, well, this is what I can tell what it is. Which is, it's so unscientific that it's like, there are people who you may categorize a certain race and they don't even categorize themselves in that race. Yet we're making prescriptive diagnostic decisions based off that. Any thoughts or questions so far? I need to see what the timing is. Oh yeah, I'm close to time. Any thoughts or
I
questions?
had a question, Edwin.
Yeah.
It sounds like you were saying with the cesarean deliveries that you would want them to look into the genetic differences as to why there's a difference, why more people of color would need a cesarean delivery. You would want to look at the biological differences, or no?
Well, I would say after we look into the social differences, right? Is there economic reasons? Is there
Totally
racism existing in the hospital? Was there issues in the way that they receive their care pre-birth? There's so many different things, but if science is saying that it's biological, then that means it should be biological all the way around, not just based on race. Because race doesn't actually inform much for me. What is helpful is where our geography, our ancestry, and sure, genetics has a role in that. One concern, I think you're raising a good point, is people say, well, great, epigenetics is going to solve this for us. We'll just look at the genetic code. We'll see if someone has a particular allele, and then we know what we can look for. It's helpful, and we also have to be very careful because we can fall into the same trap of what we do with race and essentialize genetics and say, oh, well, you have this allele, so this is what's going to end up happening. Sorry. And asking the question, well, how did that happen? And it's going to take time. I think it's going to take more study. It's going to take us advancing in technology. But at least at this moment, I say race is not the answer.
Yeah, I agree. I think race is a really poor surrogate. And I think it's, the poor man's attempt to look at, polygenetics, all these genetic influences on a health outcome. So maybe with hypertension, while it's not race, maybe there's 2,000 genes in the human genome that affect your blood pressure, and maybe certain groups based on their ancestry have a different combination of genes that predisposes them to having hypertension. Just like CF in Northern Europe, more people are likely to have cystic fibrosis. That's obviously not polygenetic. That's just that one gene. But I think it's just complex. And I think, using race as a surrogate is not great because it's so inaccurate and there's so much variation within each race that it's not a useful tool. But it's going to be interesting to see where genetic research kind of leads us and how we're going to use that and all the ethical implications with that. It'll be fascinating.
Yeah, for sure. No, you're right. You're right. Because we miss a lot of things, right? I had a student who was allowed me to share the story. It was a white student who told me after I gave a similar talk, well, I grew up with sickle cell trait, but none of my doctors believed that I had it. My parents were like, look, I think we should do the test. His first provider was like, I'm not doing the test. That's a Black disease and you're not Black.
Yeah, and that's just lack of education because we know there are people who aren't Black who have the sickle cell trait. But yeah, someone just said that, we shouldn't over rely on genetic drivers because then we're going to neglect the social environmental factors. I think you have to look at both. I don't think you can I know there's some research coming out that they're thinking it might be 50-50. Maybe it's not 50-50. Maybe the ratio is different. But yeah, you got to look at the whole picture. So I agree.
Yeah. Oh, sorry, I didn't even look at the chat. Thank you, Anna and How and Priyanka. Yeah, we wrote a piece with Monica McLemore, Rhea Boyd, and Dr. Lachelle Weeks. And it's been surprisingly received well. We changed 10 scientific journals, their editorial boards guidelines to include that if you're going to talk about race in any fashion, then you have to talk about the social conditions that are leading to these outcomes. Because what we found, and as you were suggesting, is people just fall to, and they said it in a number of papers, well, we don't know why Black or brown people have higher rates of X, but we should look, it must be a racial genetic component. And we're like, what? How? Like, did you study that? They didn't study it. It wasn't part of their analysis. It was kind of, and we're asking people, like, do they teach people in biological research? Like, if you don't know the answers, just say it's racially genetic. Because it just felt like they just kept coming up. And so I agree with folks that, well, genetics could be sexy or attractive, or that it's something that could provide better answers. We can't be wholly reliant on it because, true, like I said, and we said in the paper, it's not race, it's racism. I just hope, I hope we can pathologize racism. Like, how do we put that on the sheet? How do we put that on the intake form with our patients that come in? If we ask them what race they are, do we also ask them, have you ever experienced racism? And if they have, if they're willing to share that experience, at least ones that they remember. And some people say, well, Edwin, why is that important? Why does it matter? That's too political. Because the data tells us if you have experienced compounded significant trauma from racism, you have elevated people's mental health issues, stress, increases likelihood of hypertension, PTSD. There's a study that shows that Black men who reach middle age have a level of PTSD equal to that of someone who returned from the Vietnam War because of racism. If that's true, why aren't we asking these incredibly necessary questions about people's health? And I think we just have to get over the discomfort. Okay, there's a great chat going on. I'm actually past my time. I appreciate you all. As you can tell, the way I give my talks, I don't have to make it through my slides. But if we make it through the parts where we're thinking critically about this, I'm happy. And so I'm glad we were able to do that.
Thank you, Edwin. I wonder how much education is happening with our faculty within UW and our attendings, because I think pretty much every single time race in medicine or racial differences in different calculators, et cetera, have come up, a lot of like my attendings have, when pushed and scrutinized on those differences, almost always, without missing a beat, resort to talking about racial genetic differences and squirm and feel uncomfortable talking about social differences to the point of not even acknowledging it. And these are people that are brilliant within our institution, that are smart, like capable, read studies, review studies. You know, they're not just like junior faculty, like they're people that a lot of others look up to. And that's incredibly disheartening to see. Yeah, so I don't know if you had any thoughts or experiences with that.
Yeah, you hit it on the head. It is the tallest mountain that we are climbing at the moment. But we have created a great group of educators around this particular issue. And we are moving towards having required learning and training for our faculty to talk about these exact things, in addition to LGBTQ issues, trans folks. Like, what we're learning is that you all and our medical students are pushing our providers, our attendings, in ways that the attendings are like, I feel like they know more about this than I do. And you do. Like you all have spent more time sitting with it, right? Learning about it, talking about it. There is a discordance, especially we're talking about someone more senior who's probably been doing this for 30, 40 years. I'm not saying the learning is stagnant. As you mentioned, they are brilliant in the fields of their expertise. I think what we need to do is broaden their understanding that their expertise also needs to include these issues of equity, race, and other forms of oppression. That's going to, so it's less that they don't want to learn about it. I think it's us, we have the challenge of saying, actually, this is part of your learning. And if we don't know this, we're falling short of the full expertise we need. And that's going to have to fall also on the responsibility of the boards, of the renewals of boards, right? Like, are these questions that are going to sit there from your med school steps to getting re-upped every 10 years? And I think that's changing for some specialties, but those questions need to be on there as well. And someone mentioned, I'd seen it on step one. It's like, and I think maybe you've seen the meme on Twitter. It's like, oh, here's the catchphrases for the racial medicine that you need to know for step one. If it's African-American, it's these 3 things you need to consider. If it's Latino, it's hypertension and diabetes. Like some people are like, yeah, well, that's how we pass the exam. Yes, it is. And I've told people, like, let's get you to pass the exam. But the effect of that also is communities who see it have now internalized that pathology that, like, I mean, my grandmother said it. When she was told she had diabetes, she came back and said, mijo, I have diabetes because I'm Latina, and you're going to get diabetes because you're Latino. And I did that. I was like, okay, sure. I don't know. I'm 12. But that sits with you. You hear it in Black communities of, oh, well, look, we're going to get diabetes. This is how it is because it's what we do. It's how we eat. So we're not going to stop it. It becomes now a defeatist point of view because medicine has pathologized it. Where if we take the other approach of, no, this isn't something that you have to own. This is something we can actually move from, we can learn from, and start changing health. We can start finding more equity in your health and the health of future generations. But I think even the way we talk about it needs to be different. So I'm just trying to read the comment. Yeah, any other questions?
And residents, we'll probably start the next session at just a couple minutes after 10. So if you need to take a break, we can continue talking here, but please feel free to take your quick break as well. Lots of great stuff in the chat.
Yeah.
Keep up with.
I do have to run. Lauren and everyone, thank you all so much.
Thank you for being here today. We so appreciate your time and discussion and engaging with us. So thank you.
Yeah.
Thank you, RDC, for coordinating.
Dr. Cabrera, good to see you. I didn't realize I put the big screen on. I was like, oh, I know a face. Well, appreciate you all so much.
Thank you.
Thank you so much.